Oh, you get that?
Whenever you're ready, just go ahead and start. Just get their attention and you can go with that.
All right.
You're just going to have to talk really loud and get them settled down.
Thank you so much for joining us today. My name is Amy Knight. I am a neuropsychologist on the faculty at UAB Medicine. I work as a clinical neuropsychologist, rehab psychologist for Spain Rehabilitation Center. And I'm here today to talk to you about post-traumatic stress disorder. For starters, I have no financial relationships or affiliations to disclose other than the UAB one, and I will not discuss any off-label use or investigational use of medications in my presentation. So the objectives today are to talk about PTSD, but really to leave you with an understanding of when PTSD, why PTSD, and what to do with it, particularly in the medical setting. I'm going to describe key criteria, identify neural circuitry, and understand psychological and behavioral therapies with some discussion of the agents pharmaceutically for integrative treatments. But my main goal today is to really leave you with a sense of bench to bedside, and in particular to think about the patients that you are seeing who are likely to be experiencing some degree of a medical traumatic event, whether it was a car accident or a cancer diagnosis. Treatments that we are part of the healing process in are very often in and of themselves traumatic events. And so I really do hope today will leave you with a sense of understanding of the neurologic underpinnings of PTSD, the normative aspects of why we have these acute stress reactions, and specifically how to be involved as part of the treatment team for facilitating recovery and to address treatments for PTSD. So for starters, who likes snakes? So not everybody likes a snake. I'm actually not particularly phobic of snakes, but if you react to any sort of inherent environmental cue, you all have a normative sense of what it means to jump back. How about these suckers? Anybody got these? So I don't know if you could tell, I'm not from around here. You guys got poisonous spiders in your houses. That was new to me. This is a brown recluse, and these suckers are all over my house. And I can see them from like 12 feet away because I've gotten very good at identifying. We otherwise have a catch and release program in my house, but not for these bad boys. They're going down. How about a fear of flying? Ever heard of one of those, right? It's not particularly rational, right? It's safer than driving. People will drive themselves to the airport just fine. They're at a far higher statistical risk of being injured on the highway than they are ever going to be injured in an airplane. And yet, people are anxious. So we have a general understanding of where these nerves are coming from. We also have a general understanding that this is not abnormal. In fact, this is critical to our biological survival. It is part and parcel of being a human being, that we are out into the world, which is not always a safe place. There are scary things that go bump in the night. We need to be understanding, perceiving, reacting. We have to understand threats as viable threats or things that are otherwise safe for us. If we are triggered, which is a very popular word these days, but that's exactly what's happening. When that stress response system is triggered, there is a system that comes online to deal with it. Because things just went sideways, and you better have your act together, because we're going to have to do some things. So I'm going to go over some of the direct neural pathways in some detail and to talk about the normal fight or flight, because I don't think we can understand an acute stress disorder like PTSD without understanding the biological imperative of acute stress. How about this one? Public speaking? Anybody nervous? I'm a little nervous. I had a lot of coffee this morning. That was probably a mistake. But there's also a biological advantage to some of the nerves that we have day to day, right? So if we are just a little bit nervous, we have this understanding of a human performance curve. If I have just enough anxiety all week, I got my slides in on time. If I have just enough anxiety last night, I was rehearsing some of this instead of sleeping. We have things on our mind that get us up in the morning, get us to work on time, get things done. And an optimal level of performance does come from an optimal level of stress. Stress isn't always a bad thing. However, if we have crossed over to chronic, unrelenting, unremitting stress, we move into this factor of fatigue, exhaustion, burnout, breakdown. Okay, back to snakes. So let's stick with the snake metaphor for a second. And what happens if we are taking a walk in the woods and we come across this snake? So Joseph Ledoux, who's one of our preeminent emotion scientists in the field, established kind of the fast and slow route for fear processing. And so our sensory perceptive organs will take in the visual image of a snake. And there's a very primitive, old, historic trace memory there that makes snakes scary for a lot of us. There's a slow route that might step back and go, oh, look, it is a snake. Does not look like a poisonous variety. We are fine. But that's going to take too long to process, and we've already been bit. So if we have a poisonous snake in front of us, if we hear a rattle, if we see the moving, slithering of it, we see those markings, we're going to take the fast path. And that is the direct sensory link between thalami nuclei and the amygdala, because the amygdala is going to move much faster without even thinking. We don't have to fully process our snake here. All we have to do is register the threat at the subconscious peripheral level, and we can jump back. So that's what we understand about our fight or flight survival response. We have these neurotransmitters that are sensing a threat mechanism needs to be put into play. We have a noradrenergic system, norepinephrine through the locus coeruleus, that will gin up these transmitters, release throughout the brain for alertness and vigilance. But this is short term. Neurotransmitters are very fast and very brief. So we are going to need something else to come online to sustain a fear response. So that's where our HPA axis and the autonomic nervous system is going to have to come in. So this is our autonomic nervous system. It mediates fear behavior as well as other aspects of ganglionic neurons in the periphery, smooth muscles and glands and cardiac muscles. Ultimately, we understand it to modify parasympathetic versus sympathetic responses. So if we need to have our cardiac output ginned up, it's going to cue up a sympathetic system. We need to breathe faster, harder, deeper. We need to suppress digestion and other bladder functions, and we are not sleeping, right? There's snakes in the world. We have to respond. In order to do that, we are going to need to have some hormones. So that's how the brain does it. We have transmitters which will then communicate through the hypothalamus to the pituitary, and the pituitary gets the hormone systems involved. Adrenocorticotropin ATCH, otherwise known as cortisol, coming from adrenal hormones, released to activate the sympathetic nervous system. So then you are on steroids. And what we think is going on with things like affective arousal that's dysfunctional is the feedback system becomes compromised. So again, the hypothalamus pituitary adrenal axis is good. It is normal. It saves you from the snakes. And more importantly, what if it was just a stick? Silly. It's just a stick. You're fine. You have a top-down system. Your frontal lobe will take a minute to realize, oh, no, okay, everybody stand down. It's fine. It's a stick, and we can move on. So we have this bottom-up system that turns up the juice with that cortisol shot that you get out in the real world, and then we have to turn it down if the threat is not really a threat. So what if the threat is really a threat? Who's afraid of death? Everybody? No? Catholic Smith? No. So what if you are in a car upside down with a broken femur and there's smoke and the jaws of life are kicking up some sparks? Intense fear of death. And I would posit that every single person here in the right circumstance would absolutely succumb to an acute stress reaction. It is normal biological necessity. And again, if you think about it, what do we need to do to survive in this moment? With my patients, I give them a scenario that's very primitive. I talk about going out and foraging in a field and there's a tiger. What are we going to do about that tiger? I could be afraid of the tiger. What good does the emotion do? Nothing. The emotion isn't helpful. That's collateral. What fear actually does is biologically prepares me for the response, right? So my heart starts pounding, I got to get blood circulating, I start breathing very rapidly, I have to get a lot of oxygen because I am going to run, right? I have this burst of adrenaline. I also have a couple of interesting things. I have something that's called vasoconstriction, right? So in case I get bit, probably not going to bleed out so much. I have something called hypercoagulability, clotty, right? So I don't bleed out. That's normal, basic biological survival, and it gets us through the minute, the hour. What about weeks? What about months? What about chronic stress? And that's really what we're talking about here. When we look at the clinical diagnosis of PTSD, you start with an origin event, some kind of exposure to actual or threatened death, injury, sexual violence. The DSM-5 has recently expanded this criteria to experiencing it vicariously, right? You don't actually have to be present for that threat personally, and you don't actually necessarily have to feel like your life was threatened. It just has to be upsetting enough. It's characterized by intrusion symptoms, thinking about it a lot, avoidance behaviors. I don't want to think about it anymore. I don't want to talk about it, and I'm not going back there. I'm not getting back in the car. I'm not going back to work. I don't want to see that doctor anymore. He hurt me. Negative thoughts or feelings. So this idea that maybe it was your fault or preoccupied that it was somebody else's fault, not fully rational, not completely balanced. A lot of guilt and shame falls into this criteria. And then ultimately, reactivity. So that jumpiness, that kind of generalized anxiety, inattention overall, sleep disorders. So that's the general criteria of PTSD. But it also shares a lot in common with other diagnoses. Obsessive compulsive disorder has a lot of intrusive thoughts. Major depressive disorder is also often a comorbidity of PTSD. Other psychiatric disorders are characterized by flashbacks and very vivid hallucinations. And traumatic brain injury, so that can occur as a comorbidity depending on the nature of the trauma. And then you have a whole other host of difficulties like headache, other concentration difficulties, and other disorientation. Acute stress disorder is the same as PTSD, it's just a timeline, right? And I would argue that 100% of everybody has an acute stress disorder in the first hour or day of something pretty awful. And if you think about it, if Sheila hurt your feelings, you might be up a little bit last night thinking about that and moving on the next day. We often have things on our mind. We often think about our day. We often think about things that didn't go well. And then when something very traumatic happens, all of those symptoms are true for really virtually everybody. But what we see is a rapid decline in symptom presentation within those 30 days. So it is well established that those first 30 days are not necessarily a good indicator of who's going to have persistent PTSD. When you have persistent stress reactivity, it can cause any number of functional implications. So we have negative emotional functioning, including just anhedonia and not enjoying anything in life, an increased risk of suicide, and other dysfunctional relationships. We can have a reduction in behavior functioning. So we're missing school, we're missing work, we're not participating in activities. For some reason, nobody ever wants to go back to Walmart. I don't know why that always is, but that's always super scary. Difficulties with interpersonal relationships, so you see withdrawal from families and friends and social activities and gatherings, and generally cognitive complaints like attention and memory, as well as a hallmark symptom of sleep disturbance, which is really endemic with almost everybody and is so critical for healthy emotional and cognitive functioning that we always need to really ask about the sleep aspects. And the nightmares are going to be a part of the problem with PTSD. So the lasting effects on the neuroendocrine system are in part because of what I said. We have engaged a hormonal reactivity system, right? And those hormones have long-term effects on norepinephrine and cortisol systems. And there are aspects of brain functioning that are particularly sensitive, including the hippocampus, the amygdala, and prefrontal cortex. We know from studies that look at prolonged exposure to stress, we see structural abnormalities. So with Vietnam veterans with combat-related PTSD, there's a documented 20% reduction of hippocampal volume. Police officers with PTSD have also been shown to have smaller hippocampi. So if we look at this little hippocampus, what we are seeing is a deterioration for some reason. And the mechanisms are not well understood, but this is in part what we need to be addressing. It is not, like all psychiatric conditions, it is not just in your head. Well, it is in your head, but it's not because you're crazy. It is because there is a neurological phenomenon happening, and it is persisting, and it is causing brain damage. So if we look at the clinical course between acute stress disorder and post-traumatic stress disorder, which can be diagnosed after that 30-day mark, what we see is towards the end of the month, you still get a chunk of folks. About 25% of people with that acute trauma exposure will be endorsing enough symptoms to meet criteria for acute stress disorder. After 30 days, we roll over to actual PTSD. It's only about 20%. At 2 years, we're down to 10%. At 5 years, it's fairly stable, a little bit better, 8%. But what is interesting is the difference between 30 days and 2 years. And what that would really suggest is anywhere between a 50 to 66 spontaneous remission percentage, right? So there are things that help people get over it. It isn't that they weren't traumatized. It was a very upsetting experience. They had the full range of stress reactivity, and yet the majority of people recover. And the majority of people recover quite quickly, right? So 2/3 to 3/4 within the first month. No treatment needed. So why? So what we understand about the limbic system and the HPA axis and the upregulation of stress response and the downregulation of the parasympathetic nervous system coming back online so we can eat and digest and sleep, is the relationship between the anterior cingulate, the dorsal medial prefrontal cortex, the dorsal lateral prefrontal cortex, so your frontal lobes, where we do all of our big thinking, and the amygdala, which you can see right there is that little almond-shaped guy. A lot of connections between the frontal lobe and the memory circuitry. So the hippocampus is connected to the amygdala very closely. They share common pathways with the stria terminalis and the fornix, looping around to the basal forebrain with acetylcholine. It helps us remember the scary things. Because again, those are the things that are really important to remember. That was not good. Let's not do that again. So if the system is good at remembering the bad things, why is it not good at calming down afterwards? Once we figured some things out, once we're safe again. And the presumed mechanism is the connectivity between the frontal lobe and the amygdala. So if we want to look briefly at some research as to some of the underpinnings of that technical detail, I'm going to walk through some of this. So some of the research I do at UAB is in neuroimaging. And so we had an investigation of pathological stress response following acute injury. So these are patients recruited from the UAB trauma burn ward within days of their injury. And then we stuff them into a scanner with a head coil on less than 30 days after that injury. It's really hard to do, right? Do you try to talk somebody who's been trapped in a burning car for hours to get into a scanner? So I am a clinician. I am 100% a clinician. I do not do this research alone. So I want to just acknowledge for a minute collaborators. My co-PI in this study is David Knight. He's got many other folks in his lab. Other folks in trauma were involved. You might recognize the name. This is my ex-husband. So if you want to think about trauma, try doing research projects with your ex-husband. So this will get just a little weird. I apologize. So when we were looking at, when I came to UAB, I didn't know I was going to be working with trauma patients, but I just happened to have an ex-husband who is a learning and memory neuroscientist specializing in Pavlovian fear conditioning through functional neuroimaging of the amygdala. Ladies, he's still single. But turns out I needed one of those because I wanted to understand better, and it seemed like a good collaboration. I like to tell people that I am legally obligated to show half of his slides because he got half the research in the divorce, but the reality is we did this after the divorce. I do get to be snarky for the whole talk. For this part of it. These are his slides, and a lot of times we do this talk together. I'll be honest, it's more fun to trash him when he's here, but rest assured he knows that's happening right now behind his back. All right, so I'll talk about the study design. I first wanted to talk about the slide design. It's a black back with yellow lettering. It's super obnoxious because you can't print this out in grayscale, and it's hard to look at. It's very inconsiderate. Otherwise, the study design was looking at our trauma unit patients. We ended up recruiting 20 symptomatic acute stress trauma patients, matching them to 20 non-symptomatic control patients and 20 MRI incompatible patients. Anybody doing fMRI research with a functional magnet needs to understand you can't put all kinds of people in a magnet because for some reason everybody has metal fragments in their eyes here. I don't know what that's about. A lot of people have head injuries, so that was an exclusion criteria. We were also trying to eliminate pre-morbid psychiatric conditions and substance abuse, which is also super popular on the trauma unit. So we were down to about a 1% success rate. So it took us several years just to get 20 symptomatic acute stress subjects, largely because many folks are not MRI compatible for research purposes. All right, so the paradigm, which I will explain briefly, was basically you stick them in the scanner and you blast them with loud noise, a white noise. He used to do this research by strapping bands to your ankle and giving you electric shocks, just like the rats. And we were in graduate school. I should have known that that was a mistake because I was in the study and it was unpleasant. This is also fairly unpleasant because it is a blaring white noise sound. It is jarring and startling, but you get a signal, right? You get a warning. Sometimes you'll get, like let's say it's a blue triangle versus a red square, right? So it's geometric, and if you get the blue triangle, you're not going to get the white noise. So you can rest easy. As soon as you see that red square, though, you know the blast is coming. So it's really a study about threat expectancy. When might we expect to be blasted, and how does that affect our stress response? They're also looking at skin conductance data and startle electromyography. Cortisol levels are also collected. This is the model, basically dorsal, lateral, prefrontal cortex, dorsal medial, ventral medial, connectivity to the amygdala. And our hypothesis was that the frontal lobes are essentially offline. You're going to see stress-induced increased amygdala activity and increased physiological stress response. And we were looking at baseline at 3 months and at 6 months. I just wanted to do quickly, and you really dodged a bullet here because this part is super boring when he does it, but 101 for Pavlovian associative fear learning, right? Most of us have heard of Pavlov's dogs, which is another kind of associative learning. You ring the bell, dog salivates. It's automatic, right? And it is conditioned, right? There's a conditioned stimuli, which is the bell. And it causes an unconditioned response. So then the Pavlovian people talk about CS+, which will be your warning cue. Again, in this case, it's the red square. CS- is the opposite, right? It's a safety cue. And then there's a period of time where you just don't know. So an unpredictable threat will be present. The reason that associative learning, in particular associative fear learning, is important is to understand for a minute why it is normal, again, in our brain to have a fear learning system in general, right? One trial learning. If something is very bad and we survive it, we need one trial learning. We need to learn right away that that was super bad. And we have an unconditioned response, right? So if you see that snake, you are going to jump back when you see it. That's not a good example because you're going to see it. If you touch something hot, you will pull your hand back because it hurts. That's an unconditioned response. What you have to learn is the conditioned aspect of it. When it heats up and is red, you have learned not to touch it. So the importance of the conditioned response is it prepares you for the unconditioned reaction. I did my best. Okay, so this is where he would be like blah, 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 blah. So we looked at structural integrity of the uncinate fasciculus, and what you see here is TE versus HC. So TE are our trauma exposed versus healthy control. And what we see with the connectivity between frontal lobe and amygdala, uncinate fasciculus is that pathway, we see better anisotropy, which means better integrity of the uncinate fasciculus in our healthy controls. So even within 30 days, the trauma-exposed group already is showing structural changes, reduction in the connectivity. And it is conditional, it is significantly related to symptom severity. So not just do I have a change in my anisotropy, it is related to how upsetting was that event. Folks with more symptoms, acute stress reaction, show greater disruption in this circuitry. We see the same thing with spectroscopy. So if we look at the glutamate system in the anterior cingulate, glutamate is known to be involved in this HPA axis, part of our stress response system. The three groups that we have is trauma-exposed high symptoms versus trauma-exposed low symptom. So again, some folks have trauma experiences but do not have a stress reaction. It's only 25% who do. So again, the majority of people have trauma exposure. That one day maybe they're upset, but largely trauma-exposed low symptoms are identical to the healthy controls, or non-trauma exposed. But the interesting finding here is that if I am symptom expressing, something's going on with my biochemistry. The metabolites are off, glutamate and glutamine, when we look for the MRS spectroscopy. And that also correlates with symptom severity. Blah, blah, blah. So the other thing with functional is to look at how is your brain responding to a stimuli that is predictable versus unpredictable. And this is very fascinating because it has a lot of implications for treatment. And the finding is, it's easy to see, but the lower bar on the graph, or the lower line, is the control group. And the fMRI signal is part of the dorsolateral or dorsal medial prefrontal cortex is what we're looking at. We're measuring the signal. And when you see unpredictable cues, when you don't have a square or a triangle, you don't know what's going to happen. What you see is the same reactivity between the PTSD group, and now these are the folks that have PTSD symptom expression, right? Same reactivity as the control group. But what is really fascinating is when you get a nice split like this in a clinical population, the PTSD group are very reactive, and actually it's the opposite. They are less reactive. They have a diminution of frontal lobe activity, so that's relative to their premorbid baseline scans. The predictable cue is a safety signal. If I don't have PTSD, I can recognize a safety signal. What we are seeing with the trauma-exposed group is failure to register safety signals. Another way of looking at this is in the ventral medial PFC, the trauma-exposed group have less activation in the blue there versus the healthy controls. And also in the amygdala, we see overall activation. So what we thought we might find, we do find, and we find it pretty robustly within 30 days of an acute trauma event, that the amygdala is overreactive, the frontal lobes are gone offline. They are not helping to deregulate, to downgrade that emotional reactivity. And we see this specifically with warning and safety cues as well. And done. Okay, when we turn this part of the talk back over to me, I feel obligated to say he will say something snarky like, and now Amy will give you a puppet show. I am going to. So, because the puppet show is helpful, and I would argue is the definition of re-engaging your frontal lobe, right? So if I can teach you my puppet show, you can teach your patients the puppet show because it's super easy and it requires a little imagination and creativity that the neuroscience just didn't really have. But I have faith in y'all. So the way this puppet show goes, and did you all bring your puppets? No, you did. I see them all. All right, so puppets. This puppet goes like this. Do it! This puppet goes like this. You will never forget this, by the way. Once, right? This puppet goes like this. This puppet goes like this, all right? This puppet is called lizard brain, and it's deep tissue. It's our amygdala and our hippocampus and all that circuitry down to our sympathetic nervous system. Lizard brain. This puppet is our monkey paw. This is our higher order reasoning. It sits on top, right? This is the disconnection. Our monkey paws are not working. We are all lizards, and that's what we're going to work on. We are going to make you less lizard-like and get us back into higher order reasoning. And again, just the act of explaining that to somebody, psychoeducation, because I assure you if I go through the hypothalamus pituitary adrenal axis, I have lost them. If I monkey paw and lizard brain them, they will remember that forever. They always do. And they always come back and say, oh, my lizard got away from me again. It's a good analogy and it's a good visualization. And again, by definition, you're into your frontal lobes. And we know from research, we have dysfunction in the frontal lobe. So what are we going to do to bring it back online? So moving on. Post-crisis, and this is where you will see a lot of people who strike you as maybe being Ptsd, right? They are agitated, they're not sleeping, they are shell-shocked or they are whiny, they are thinking about it, they are talking, they are having panic attacks in the hospital, they won't go to therapies. So post-crisis, here's some things that might be helpful. So first off, the first 30 days is no time for crisis counseling. In fact, the research would suggest that you can actually make things worse by trying to do crisis counseling in that moment. However, what we are looking to is to rebuild a sense of integrity and control. And so what that means is if you want to talk about it, it's a safe space, but I work on the inpatient unit, and I go down and I say to people, and it's the first thing I say, I've read your medical history, I know why you're here. You are welcome to discuss it, but you don't have to, and let me give you some reasons why this is not the time or the place for that. Truly, we need to get you home. We need to get you safe. We need to make sure medically that you're stable. We need to make sure you know how to wipe your butt. And if you don't, we're going to train somebody else to do that for you. But this is not the safe space for reprocessing traumatic memories. So one of the most important things I do as a psychologist on a trauma unit is to give people permission to not talk about it. And to give permission to family members to stop people at the gate who keep coming in and go like, oh man, that was awful. And asking people what happened and tell me what got wrong with the machine when it ripped that. You don't want to have that conversation in the hospital. And I got news for you. Not everybody's your inner circle bestie friend. A lot of people are just super nosy. And there's a reason for that too. I mean, it's really scary when you see things go sideways. And vicariously, you weren't even there. But I'm going to look at that traffic accident. I'm going to look at that burning bridge. I am going to look at that. We all have this instinct to look closely at something that didn't go right because it's a cautionary tale. So again, it's a natural inclination for people to come out of the woodworks, but it is also potentially re-traumatizing to have to talk about it while you're still in acute pain, while you are still in recovery, while you don't even have pants on and are trying to just get through your day. So that is honestly one of the most important post-crisis strategies I could give you, is give people permission not to talk about it now, but also open the door for, this is normal. We expect 2/3 of people to just spontaneously remit within a month, but give it a couple of weeks. We also encourage you, if it's persisting after a month, let somebody know. We have resources. Come talk to us, and let's talk about some treatments. A couple other things to maintain is human contact, comfort, basic needs, security. Find those people who are in the inner circle and figure out who they are going to be so we can create a safe environment. Not everybody has that. And provide some education on what is normal about this period. We do expect you to have intrusive thoughts. They should be reducing over time. We expect you to have nightmares. That's normal. That is your brain processing things at night. You may not be sleeping well in a hospital bed. You may have pain that is also a factor in keeping you awake. Nightmares are normal. They should get better over time. And being reactive, being jumpy, having panic attacks on the floor is normal and is not suggestive of a need for overdoing a ton of medication. People get through their panic attacks. I'll show you how. And the main thing is to warn them about, do not go home and lock yourself in your cave, right? After a traumatic event out in the scary world, it is human nature to want to lock yourself in, have a pajama cave day. I'm not going. Again, I'm not going to Walmart. Walmart is so big and so many cars and so many people and so many bright lights, so scary. People immediately start to shut down. And just like the physical activity we encourage with every kind of medical condition, you have got to get out of bed. It's the same thing for psychological health. You have got to get out of bed. You have got to get out and about. So to be very cautious of any kind of social withdrawal, any kind of behavioral avoidance, and the other kinds of avoidances that people use, substances, alcohol, tranquilizers, or reckless behavior. So things to watch for. So just a word of psychopharmacology. Psychopharmacology is part of an integrative treatment approach to PTSD. It is not a sole approach. It is not the first line of approach. We'll get to that. But it can be helpful as an added therapy. The first line recommendation from the FDA is the SSRIs, selective serotonin reuptake inhibitor, specifically fluoxetine and sertraline. Also, antihypertensive medications like clonidine can be put on board. And then sleep aids that are specific to nightmares. Prazosin regulates aspects of nightmares' vivid nature. So it can help make a nightmare less scary. Doesn't necessarily prevent the nightmares from happening at all, but it can. And those medications are certainly reasonable to consider getting on board, especially if people are pushing towards the end of that 30 days. A word about anxiolytics, and this is just my PSA talk part of the show, I guess. You know, I'm out of my wheelhouse, right? I'm not a medical doctor. I do not prescribe, but I can read, and of course there's problematic medications and there's a lot of abuse, and anxiolytics are shown to be counterproductive for stress disorders. Contraindicated, worse outcome, dependency, and abuse. My guess is you all already know that, but in my practice as a neuropsychologist, I would say half of the people come from memory loss really actually have a benzo problem or some kind of opioid problem or at least a sleep problem, right? It's not actually something that's systemic to them other than the systemic effects of an anxiolytic. So just a couple of points from a cardiologist that I pulled off the Chemovin MD webpage. She got a Xanax prescription after one of her hospitalizations, and this is a cardiologist. She knows better. But she didn't realize that this physical dependence will take effect in days or even within a week. And it's also the same problem we have with opioids, right? You know, you get on these things for about a week, and you're going to start to feel withdrawal symptoms if you stop them. And so we have a lot of messaging with benzos and anxiolytics, and this is true for opioids too. Well, if you don't have an addictive personality, that shouldn't be a problem. As long as you don't abuse it, I take it just the way I'm supposed to. It doesn't matter. Taking it every day for 7 days, dependence. And then if you have dependence, what you have when you stop taking it is withdrawal. And withdrawal symptoms are often intolerable and confusing. And people aren't particularly prepared for expecting it. The most common thing they say when they've tried to quit cold turkey is, oh my God, it was really bad, so I must really need it, right? They say that with opioids too. I have to have this because if I didn't take it, I'd be in trouble. Well, you didn't go through a titration plan, so we really don't know. But we do know that that withdrawal symptom profile is going to be problematic. And there are a lot of symptoms that come from benzodiazepine use in general. You see all those pretty well? How about those? You see a bunch of them? So again, just in passing, if you and this is definitely not in my wheelhouse, and I will always tell folks, I am very concerned about your benzodiazepine use, especially when they come in, they're taking Xanax just a little bit, 1 milligram, 3 times a day. And then they double up at night for sleep. And it does make you sleepy, so I get that, but it disrupts deep sleep. So tranquilizers and benzodiazepines do not actually give you better quality of sleep, they just make you unconscious. And that's different. That's different. So we'll do something else. But what I encourage folks to do is not to go cold turkey. And I warn them about acute withdrawal symptoms. And I warn them that they need to get with their providers and have a conversation about a taper. And that there's really nothing I'm going to be able to do in treatment with somebody who's taking Xanax 3 times a day. There's simply no reason for that. These benzos should only be on board about 2 to 4 weeks. Now, don't get me wrong, there's a time and place for a little bit of Xanax every once in a while. You know, there's an acute reactive in the hospital, somebody's freaking out. You know, there are moments, right? Xanax has a time and a place. I wouldn't say never. But not daily. And even the longer acting ones, right? Unless you got a seizure disorder, I'm not a fan. But there are some good taper manuals out there. This is one that I found from the UK. Moving on. All right, so what can we do? Let's get to treatment. I want to talk just a second about some of the other treatment recommendations. It's all within the field of psychotherapy, you know, cognitive behavioral processing kinds of therapy, CBT. Some folks take a more behavioral approach, prolonged exposure therapy. Well, I guess that's where you're really just kind of rehearsing a memory and then both in vivo, in life exposure as well as imaginal exposure. Cognitive processing, which is really challenging some of the unhelpful beliefs. There's a field of eye movement desensitization, reprocessing that also is shown to be effective. All of the cognitive behavioral therapies have been shown to be effective. The VA has their own manualized treatment. EMDR folks have their own manualized way of doing it. Ultimately, not that many of you in here are psychologists, although some of you are. Who are my psych people? Somebody? Behavioral health? Somebody? Oh, just you guys. Just the row. There we go. But I want for the rest of you to understand some of the elements of what all of these approaches have in common. And the first is understanding, truly, to give people a pass to say, you are not crazy for having this had happened to you. You are not crazy for having this constellation of symptoms. These are biological imperatives for the survival of the species. Good for you. Look what you got. But they're uncomfortable now. They're causing problems. We have treatments for that. There's a thing for that. So let's try some things. There's every reason to be hopeful that we can not exactly cure you of PTSD, but we can make it much, much better. I use this other analogy because it really sticks with people and they never ever forget it when I do it this way, so I'm going to share it with you. PTSD is like herpes. It's forever, right? Once you get it, you really are vulnerable to getting it again, right? But it can go dormant. If you can get things in your life nailed down, if you can get some control and lower your stress reactivity, you won't really be symptomatic, or if you are symptomatic, you'll have the tools to manage it. So psychoeducation goes a long way to making people feel okay, that it's not because you're broken that you have PTSD. I will say there's a little caveat to that I don't really share with people, which is sometimes it is because you're a little broken that you have PTSD. And that's because trauma begets trauma, and life experience matters. There's a reason that single trial learning is important. It's because sometimes the world is scary and dangerous. And sometimes it's the zombie apocalypse, and you need to be afraid of absolutely everything at all times. And your brain has become sensitized to looking for threats in your environment because you've seen a lot of threats in your environment. So there is vulnerability that comes from prior exposure. Childhood abuse, in particular childhood neglect, other kinds of physical trauma, sexual trauma, other kinds of experiences in life, financial loss, economic disruption, loss of home, loss of jobs, loss of friends, loss of spouse. You know, many, many things can trigger these stress reactions. And the more we have, the next time we'll be better at being afraid, because that's biologically what we are supposed to do, is to be very afraid. So the next thing we do is we want to teach and practice affect regulation skills, which I'll show you in a second. We are going to also review subjective units of distress, because I'm going to work on distressing people, and I want them to be able to tell me how distraught they are, and so we can manage it. If people are too upset, then it's not time yet. Just like in the hospital, it's not time yet. We need to get to know each other better. You need to get to know me. I mean, I'm awesome, right? But you don't know that yet. You don't know that this is a safe space where I'm not judging you. You have to come a couple of times. I have to teach you some skill sets, and you have to start building some confidence that you can do this. So once we do that, once we've established it's a safe place and you have a skill set, we can then reprocess memories. These memories are often fragments. They're often just visual elements. Sometimes they're just a smell. Sometimes they're just a physiological feeling. We need to put that memory back together like a CSI episode from start to this happened, then this happened, and then I guess I was safe again. We have to create a narrative to reconstruct a trauma memory so we have some control without freaking out. And then we take some time to grieve our losses and establish a new normal. Okay, so last slide. I wanted to just go through, this is what I do. And I was trained as a neuropsychologist, and if anybody knows neuropsychology people, we are not actually particularly good with people. Right? We are not particularly well trained in psychotherapeutic approaches, and I inherited this service, frankly, not having that much training in trauma. So I did a lot of research on my own, and then I got involved in research projects so I could learn more. And what I came around to was this particular treatment plan that has worked quite well with me and my patients. And I pretty much only see people with medical trauma, most specifically workman's comp trauma, because it is uniquely traumatizing to have your arm ripped off by a machine and then be asked to go back to work, right? It is such the ultimate insult to have the place that was supposed to keep you safe, and they say that, 0 days without and then you got hurt there, and you have to go back, right? That's particularly challenging. So the basic treatment plan is, let's get to know each other. Little psychoeducation, little ground rules, you're in charge, I am not the boss of you, we are gonna let you pace this, we have a structure, we go over the treatment plan. Second session, preliminaries. So this is the relaxation and visualization strategies. There are people who do this much better than I do. But I would argue, if you're dealing with a long-haul trucker, he's not gonna do yoga or some of this meditation that other people are very good at. So I have kind of the long-haul trucker version of this, which works for me, which is really quick and dirty. And I would argue you could use this with any of your patients who are in the middle of an acute reaction, right? So it goes like this. And we learned this from our pulmonary folks. Breathe. It's not hyperventilating breathing, and it's not even particularly a deep breath as much as it is a long exhale. So just teach them pursed-lip breathing, right? So it's a long exhale. Everybody do it. In through your nose for 2. Pursed-lip breathing for 3. Okay, do it again. In for 2. For 3. One more time. In for 2. Out for 3. If you did it right, you're a little lightheaded right now, right? Because we have excess capacity in our lungs, and we've just over-oxygenated ourselves. The other thing we've done is we've forced you to be mindful in that moment. Whether you wanted to do it or not, we already got you in your frontal lobe because you have to do a voluntarily behavioral active gesture. And so I've just tricked you out of your limbic system into your frontal lobes. You're welcome. So the other thing we do is progressive muscle relaxation. Again, people will teach this class for an hour, and I don't have time for that. So what I do is the quick and dirty version, which is, and everybody, arms out, squeeze, gun show, looking good, people. Hold it for 5 seconds, 4, 3, 2, 1. Feel that tension? Let it go. Rest it on a surface. Feel that muscle relax. This is what it feels like to let go of tension. We do left arm, left leg, right leg, the neck, done. Takes a minute. 1 minute to breathe, 1 minute to progressive relax, people. And then the final thing I teach them is a visualization exercise where we just walk through their house and I have them describe things because people can remember where they live. After that, they have a skill set to de-escalate. We do trauma reconstruction. All right, I want to thank you for your time. I appreciate you laughing at my jokes.